Well, in 1900, 20% of all U.S. death was attributable to chronic disease. By 2000, that number rose to 80%. So the types of disease that we're dealing with in the U.S. have changed. And it's also changed how we're going to deal with these diseases. Because today's diseases are of social and environmental origin, where of yesteryear, it was more microbial, physiological, and biological. So public health and hospitals need to come together to treat diseases that actually have origins well beyond the clinic walls. And that's really why we have to come together, because we're not going to improve our health outcomes if we don't really tackle the origins of disease. For the hospital executive, I understand that the easy path would be to bring some public health services into the health system so that you're doing your own epidemiology or you're doing your own hotspotting. But really the power of health data is in the aggregation across hospital systems. That's the only way we're really going to truly understand what's happening in our population. And let's really work with the public health department. They are skilled in how to address population health issues at the community level. And so if you haven't met your local public health official, set up that meeting. Maybe you and 3 other hospitals go and meet with that local health official and really pose the question, how can we work together to better achieve the shared goal, which is improved health of people, whether at the individual level or the community level? We're all working to the same goal. And our century-old experiment of doing it in parallel has proven to be ineffective. So maybe we should try something else, working together to achieve the same goal. So we've made a multi-billion-dollar investment in electronic health records in the US, and this was a good investment. And it's helped, for example, with the flu. There are any number of folks who are tracking the flu outbreak through billing. But this has really been only tapped on the clinical side. We actually can bring those data onto the public health side, contextualize them with parks and access to fresh fruits and vegetables and access and proximity to alcohol and tobacco outlets. And by contextualizing those data, they become much more powerful. And then together, public health and primary care and hospitals and health systems can actually find their problems, identify the real causes, and work together to solve them, and ultimately reduce the complexity and incidence of disease. We've had an epidemic that has cost billions of dollars and countless loss of quality life years, and that's obesity. But we've not really had good data. The data on the community side has been lagged by 2 years and often isn't at the right level of geographic aggregation. So you'll have county information or state level information. And that's kind of like walking into your provider and saying, I have cancer. And the first question would be, well, where do you have cancer? And what type of cancer? And what's the genetics of the cancer? But in public health with obesity, we can't answer those same kinds of questions. Where is your obesity epidemic? Who's obese? What are the correlates? We don't have that information. But every time you walk into your provider, the first thing is height and weight. You can go in Monday and your knee is sore and you height and weight. And when you come back Thursday for your follow-up, they take your height and weight. So the natural history of the obesity epidemic lives in medical records.